Hi, my name is Lauren Williams, and I'm the Neurotrauma Program Coordinator at UCSF Benioff Children's Hospital in Oakland. And today I will be speaking to you about neurological checks for nursing. So firstly, why do we complete neuro assessments? How do we use the GCS score? And what are the components of a neuro assessment? Lastly, how should we be documenting these? A neurologic assessment should be completed with each nursing assessment, regardless of diagnoses. However, you will be doing more frequent neuro exams if there's any suspicion or finding that would alter the nervous system. Say they fell on their head, they had a traumatic brain injury, a concussion, or tumor. Throughout this lecture, you'll hear me refer to neuro checks. And by that, I mean neurologic assessment or neurologic check, as opposed to a neurovascular check of the extremity. So how frequently should we be doing our neuro checks? This really depends on the severity of the illness and the risk for neurologic change. Frequency can range from every 15 minutes to an hour, most likely in the ED and ICU, more frequently when you're in a trauma or a code situation, to every 4 hours when patients are on the floor and the risk of neurologic deterioration has lessened. Nurses should always feel like they can advocate for more frequent neuro checks or more frequent GCS checks based on how severe the patient is. So if the care team hasn't ordered these already, I want nursing to feel empowered to speak up and advocate for more frequent checks. Throughout the lecture, I'll be providing some tips on how to do your neuro check, as well as when you should be alerting the care team. So the first one here, which I think is really important, is to inform and educate the parents early on that you'll be doing neuro checks. You'll need to do these when the patient is sleeping. You'll need to do them sometimes as frequently as every 15 minutes. So really getting the parents informed and on board will help you throughout this. Also noted there, if the care team does not want neuro checks when the patient is sleeping, just make sure that they note this in their order. So why do we complete neuro checks? As you can see on the left side, you're really looking at detecting neuro disease or neuro injury and then monitoring its progression. You'll also do neuro checks to see if your interventions are working and see your patient's response to it. You're basically looking for deterioration or improvement in the neurologic condition. Changes in vital sign are a late sign of neurologic deterioration. First, you'll most likely see pupil assessment changes, level of consciousness changes, or changes in their motor strength and symmetry. This is why we use the GCS as part of our first line neurologic observation. Some additional considerations, as I mentioned, the importance of parents, getting them to be a part of the neurologic exam can really be helpful if it's safe to do so. So ask them about the neurologic baseline. Typically in the ED scenario or a code trauma scenario, this may not be realistic and you just have to look at the patient at the status and condition of where they are right now. But they can also be helpful in calming a patient. You know, if someone's in the ED and they're really scared, they're inconsolable, their GCS is going to reflect that. Whereas if you have a parent intervene and calm them down, you can get a more appropriate assessment. I won't go into it in this lecture, but you should have a history, you should have a knowledge of developmental norms and milestones, how a 9-month-old can do something that a 6-month-old can't, and also a knowledge of infant reflexes so that you can understand when those are absent. So should you be doing a comprehensive or a focused exam? Comprehensive neuro exams should be done with each head-to-toe assessment. However, you most likely will be doing a more focused exam frequently. So in this case, you're going to be limiting your assessment to the level of consciousness, motor strength, and your pupillary assessment. But you can feel free to add in other assessments as the patient's condition warrants. So if you're taking care of the stroke population, maybe it's important to do cranial nerve assessments. If you are taking care of a trauma who has a spinal cord injury, or maybe they've just fallen out of a window or a tree, and the swelling hasn't set in yet, maybe they're at risk for a spinal hematoma or a spinal injury. So then you may want to start some neurovascular checks on the extremities like we talked about. Additional monitoring is warranted in a certain population who, again, are at risk of having neurologic deterioration, noted here. including trauma, your drownings and asphyxiations, those who have tumors, strokes, hemorrhages, seizure disorders, delirium, or progressive neuromuscular weakness. So how do you perform the Glasgow Coma score? This is a widely adopted scale. There's 3 components to it: your eye response, your verbal response, and your motor response. As noted, your eye response is simply if you are opening your eyes. It is not a pupillary exam. That's a separate portion of your neurologic assessment. How to score it? 3 is the worst neurologic score that you can get, 15 being the highest. We use this really often in traumatic brain injury to classify our TBI. So as you can see over here, a GCS of 8 and under would put you into the severe TBI category if you've suffered an acquired brain injury. Otherwise, 13 to 15 puts you in that mild range with moderate falling in between. The GCS is really broken up for pediatrics into 2 age ranges: the over 2-year-old population and the under 2 population. So looking at this scale, it's broken up into the 3 components: eye, verbal, and motor. The eye portion remains the same for the GCS over 2 and under 2. You're looking again at spontaneous eye opening for each of those pediatric categories. The portions that change are the verbal and motor portions. So as we can see, we're looking here at the over 2-year-old group. They're going to be oriented. You can ask them who they are, you can ask them their name, where they are, and they'll be able to respond to you. In the motor portion, they'll be able to obey commands. If you ask to squeeze your hand or stick out their tongue, they'll be able to do that. The under 2-year-old GCS is modified for more infant sensitive indicators. So again, the eye portion is the same. And if we look at verbal, a normal and best score of 5 for verbal would be if the patient is cooing and babbling appropriately. For the motor score, if they have normal spontaneous infant toddler movements. So how do we perform the GCS? In an ideal scenario where it's not a code, it's not a trauma, you would be able to assess if there's anything interfering with your ability to get the GCS. So these would include, is there a language barrier? Do they understand that you're asking them to open their eyes and stick out their tongue? Is there any intellectual neurologic deficit? Do they have hearing loss, speech loss, visual impediment? Making sure that these things are taken care of before you do your GCS. Also, what are the effects of the current treatment that they're on? Patients who are intubated can and should receive a GCS. You would just note this with the letter T to note that they are intubated. Also, do they have sedation on board? If possible, you should do your GCS before giving any sedating medications. When you're performing the GCS, you always want to score them as their highest possible score. So as we go through the scale, we'll note that. Also, some additional notes about orbital fractures. If the eyes are swollen, they have a bunch of facial fractures and they can't open their eyes, you would still note that they are unable to open their eyes. However, just write in the comment that it's due to facial swelling rather than neurologic injury. So again, you're going to look at those 3 components: eye opening, content of speech, and their movement of their right and left sides. So now regarding stimulation, the first point of stimulation is simply sound. It's using your voice. You always want to move from the most gentle stimuli to the most firm. So voice would be your first one, moving up by just talking to them in normal voice, then using a louder voice, and then moving on to physical stimuli. When you're using painful stimuli, you don't want to leave any bruises or marks on the patient. You're using firm pressure, but you're not trying to really inflict pain. So the ones noted here are the trapezius pinch. You can also do sternal pressure. Sternal rub is a bit more aggressive, but you can do sternal pressure. And then also, if the patient does not have any facial fractures, you can use the supraorbital notch. A note about nail bed pressure: there was a study that came out that 14% of brain dead patients, when nail bed pressure was applied, they did elicit a spinal reflex. So it's not my first go-to if if I want to put painful stimuli on, so just a note upon that. So now looking at the eye response. This is a score from 1 through 4. 1 being that the patient's eyes do not open at all. You've called their name, you've applied painful stimuli, and they don't open. 2 is if you require painful stimuli. 3 is if you just have to state their name and they open their eyes. Or 4 is if you walk in, they're looking at you, they're spontaneous and interacting with you. So now the best verbal response. This is a score from 1 through 5. 1 being no response. 2 being when you call their name or apply painful stimuli, all they can do is groan in response to that. Levels 3 and 4 are inappropriate or confused. Inappropriate would be if you ask the patient, is your IV hurting? And they tell you that there's a blue elephant in the room. There may be something else at play, but that would be an inappropriate response. Confused is if you ask them their birth date and maybe they don't know it or they don't know where they are. Oriented would be a patient who knows who they are, where they are, and possibly what time it is. The best motor response. So I is scored from 1 through 4, verbal is 1 through 5, and motor is 1 through 6. So again, as we move through here, obeying commands is your best score. That's a score of 6. Localizing to pain. This is the patient who can move their arms midline. This is the patient who's grabbing for their ET tube. Or as you're putting in an IV, maybe they're grabbing your hand. As you're putting pressure on their neck, maybe they're putting their arm up to where you're putting that stimuli. So they're localizing to pain. 4 is withdrawing to pain. This is when they're flexing and pulling away from whatever you're doing. So if you're putting in an IV, they're going to be pulling their limb away. If you're suctioning their tube, maybe they start to move their head away. Scores 2 and 3 are neurologic posturing. So someone is either flexing once you apply a painful stimuli, and we'll look at a picture of that later, or extension to pain. And the score of 1 being no response. You've applied painful stimuli and there's simply no movement. And again, if the patient's on a paralytic infusion and you see no movement, you would mark them as a none. So GCS tips. As I mentioned, the patient's family is a very important part of doing neuro checks. They're going to be watching you. They're going to be seeing that you're applying painful stimuli. Maybe the patient's not giving you responses. Note to the family that they should not be doing the exam when you're not there. They shouldn't try to repeat the exam. That you're doing it for a very specific reason. And also make note of the reasons why you should be clustering care. A traumatic brain or a sensitive brain cannot handle too much stimuli all at one point. If you have an ICP monitor, and that's great because you can see that the patient reacts to certain stimuli. But otherwise, if you just have a neurologically decompensated patient, or at risk for neurologic decompensation, you really should be clustering care as much as you can and noting that to the parents as well. In between your exams, that parents shouldn't also be going in there and applying some stimuli. Do not omit the GCS if you assume that your patient is sleeping. A GCS can and should be performed on sedated and intubated patients, and also continue it until otherwise. So reasons to alert the care team. If you notice a drop that cannot be explained by sedating medications, alert the care team. GCS documentation. I chose TBI here. We have very clearly defined Noro check frequency for the TBI population. So in the severe TBI, you're going to be doing your checks, your GCS, pupil, and Noro checks every 1 hour. Whereas with the mild and moderate, they're a little bit less risk. So you're going to be doing those Q2 for that first 24 hours in that initial acute period, and then they can be spaced. In both of these patients, or in any patient, you really want to coordinate with providers if they would like to get an exam with sedation either turned off or decreased. Obviously, you'll want to see if this doesn't produce a significant elevation in ICP. but coordinate because neurosurgery may want to get an exam, neurology may want to get an exam, the ICU may want to get an exam, ED, trauma. So really coordinate with providers, and nurses can really get everyone on the same page so that you're only turning sedation off at certain times. So the components of a neuro exam, we're going to focus on that top half. The bottom three, sensation, reflexes, and cranial nerves, will be used as needed. But that top portion, we'll talk about level of consciousness, the mental status. You've already assessed this looking at the GCS, and then we'll look at pupillary assessment, your motor assessment, and vital signs. So mental status and cognition. There's three components to this. Again, you've already done the level of consciousness. Two additional portions are orientation and memory. Level of consciousness is one of the first assessments that will change when there's neurologic deterioration. So this is really important. And also alert the care team if painful stimuli is needed to arouse the patient. So the level of consciousness, are they able to obey commands? Are they able to speak with you? Again, this is the portion where you've used your GCS, you've gone through, and this may be challenging in patients with cognitive or developmental delays, but again, you would just score them at their greatest ability. So here are some questions. In infants, you would have to assess if they're more lethargic as well. Were they previously interested in eating and now you can't really wake them up for a feed? Are they sleepier than usual? In your teenage patient, they also like to sleep a lot, so especially after an injury. So understanding what's just normal sleepiness versus what's a decreased level of consciousness. Orientation. Again, this is harder if the patient is intubated, sedated, or paralyzed. You really need to have a participatory exam here. So in determining orientation, you're going to ask the patient's name. In terms of time, it's really hard. Hospitalized patients can very easily lose track of time if they're not oriented by their nurse or people around them. So younger kids may know, what season it is, what month it is. It's really probably hard to know the exact date or day of the week. So just keep that in mind. And alternating your questions. Memory, again, we're not going to go into a large memory test. Just some quick little tips is that after some traumatic injuries, patients can have post-injury amnesia. They hit their head, they're swelling, and you can also have seizures at the time of impact. So that is pretty common to have post-injury amnesia. So you'll want to ask, maybe what's your birthday? What's the birth date of your mom? Sometimes they won't remember what their injury was, but asking some additional things. If you introduce yourself to them in the morning, hi, my name is Lauren, I'm your nurse today. Come back in 5 minutes. Do they remember that your name is Lauren? And these are just some quick little ways to test memory that aren't very formal. So again, reasons to alert the care team. These ones are pretty obvious. If you can only arouse them using moderate or painful stimulation, or if they were previously talking to you and now they've completely gone unresponsive. Some more subtle things are listening to parents. If they say that the patient is more irritable, if they're angrier than usual, if they're more emotionally labile, or they're crying and they're happy, and that's different for them, then maybe take a closer look, alert the care team, and let them know. So pupillary assessment. Here you're really testing cranial nerves 2 and 3. And you're looking, we're all familiar with PERLA. We're looking at, are they equal? Are they round? Are they reactive to light and accommodation? Again, in your sedated or intubated population, checking accommodation, which is where you're moving an object from farther away to closer and seeing if the eyes are both converging and constricting, that's going to be a lot harder. You may not be able to do that portion of the exam while your patient is sedated and intubated. So we're going to focus on, are the pupils equal in size? Meaning you're looking at each pupil independently. Are they the same size? Are they round? If they're not round, did they have a globe injury? Did they have an ocular injury? Do they have some syndrome that produces pupil abnormalities? Charge syndrome often produces that coloboma, which is like a cat eye, and it may not react to light. So, and that's the second portion. Are they reactive to light? You're going to hold your hand over, you're going to use your pen light or your pupillometer. If you're not getting a response by just holding your hand over them, then dim the lights in the room, make it completely dark. Again, this is pretty self-explanatory. What would you alert the care team for? If the pupils have changed from baseline, maybe one is now unequal, maybe they're not constricting at all, it may be a medical emergency. So fixed and dilated pupils, as always, is a medical emergency. Alert the care team. You may even need to call a code. Motor response. Again, you've done this as part of the GCS. So here you're going to look at the physical response to stimuli. Additional components are their strength, their tone, and their movement. This is much easier in a patient who's able to obey commands. You can tell them to lift their arms, legs, anti-gravity. You can do squeeze my hands, push your feet down like you're driving a car. In the patient who doesn't obey commands, this is a little bit harder. So again, you're going to be looking at, are they withdrawing to pain? Are they localizing to pain? And those neurologic posturing, whether it's decorticate posturing or decerebrate posturing. And here you can see a picture of both. Decorticate, I always remember this, is coming into your core. So you're going to have the hands flex coming into midline. That's decorticate posturing. Otherwise, decerebrate posturing, as you see on top, and this is damage to the brainstem, but you're going to see that the arms are abducted and extended. Tone, as you know, you can either be hypertonic or hypotonia. Hypotonia you'll probably see with spinal or brainstem injuries. Alerting the care team if you see new onset of posturing. Vital signs. Hopefully you guys all know this, you've seen this, but Cushing's triad is a medical emergency. You see this in the late stages of acute head injury, and it may indicate impending herniation. Bradycardia is one of the earlier signs. So you'll see bradycardia, a hypertension with a widened pulse pressure, and that's an increasing systolic with a decreasing diastolic, as well as irregular respirations. However, if you see one component of Cushing's triad, let the team know. And this is sometimes hard because you're giving sedating medications. This is also one of the reasons that we avoid propofol in traumatic brain injury, is because you can decrease the heart rate, and then you're not having the venous return. But I have seen bradycardia in some really fit teenagers who then have traumatic brain injury. So look closely, but if you start to see any singular components of this, alert the care team. Cranial nerves, I won't go over too much. I still always need a chart if I'm completing these. Again, you need a participatory exam for this. You're seeing if the patient can raise their eyebrows, if they can smile, shrug their shoulders, stick out their tongue, left, right. So I'm not going to go into that too much. Again, you need a participatory exam, and then you'll just have to pull out a chart or get the neurologist to assist you. Some abnormal eye movements you can see are as dysconjugate gaze, nystagmus, which may be a normal finding for the child. Again, you would ask the parents, or ptosis, which is drooping of the eyelid. Alert the care team if there's any new finding in cranial nerve dysfunctions, or if you see a facial droop or unilateral facial movements. If the patient can participate, you ask them to smile and maybe only one side of their face goes up. Sensation, I won't go into this too much. Again, this is part of that extra assessment that you can do if you'd like to augment your focused neurologic exam. So two things. Abnormalities and sensation may be a neurologic injury, either spinal cord or brainstem. Again, I'm not going to focus on vibration or proprioception. They're a little bit harder to do just as a nursing bedside exam. So just temperature and pain are something that can be easy. If you have an ice pack, again, you can place that on the patient's legs or hands. Pain, you can just get a paper clip and run it along their foot or their extremity, see if they feel it. But again, they would need to tell you this. So again, you need a participatory exam. alert the care team if there's any decrease in sensation. So closing out, just some additional neuro notes. A brain death exam, you'll be seeing physicians, they're doing a focused neuro assessment. However, certain parameters must be met in order to do a brain death exam. So the patient needs to be normothermic, they need to have all metabolic abnormalities corrected before this test can begin. As I mentioned with the nail bed pressure about spinal reflexes, this is also something to be aware of. Spinal reflexes may remain intact in the brain dead patient, but this does not preclude a determination of brain death. This is often one of the really hard things to relay to parents, is because they may see some movements that they think are purposeful, when in fact they're just spinal or brainstem reflexes. So that's a hard one. Understanding those will be helpful. Lastly, in the ED and the ICU, for traumatic brain injuries or patients that are severely neurocompromised, you may be using a neuromuscular blockade. This makes your exam much more difficult. Patients can't participate. You're not getting that same, midline movement. So it makes things more difficult. Just know that you're going to be paying very close attention to your pupillary exam. Pupillary constriction is not affected by a neuromuscular infusion. And also note, it's really hard to assess pain in someone who's chemically paralyzed. So you can't use the FLAC score. FLAC looks at your face, legs, arms, consolability. It's going to be 0 no matter what if you have a neuromuscular blockade on. So don't use it. It's not appropriate. It's not validated. You would use of the APP or the AAP, assumed pain or assumed agitation present. And then for your sedation level, you're going to be using the SBS. So how to document, you guys have all seen this. This is now standardized across campuses, the neurologic assessment, and then you can choose which Glasgow Coma score you want, whether that's under 2 or over 2. ED's documentation, I'm sure you're all aware of the flow sheets for traumas and codes, marking your GCS over there. Everything's clearly laid out, as well as your vital signs and noting their GCS with all of your vitals. So I think that's it. If you have any questions, again, my name is Lauren Williams. Please feel free to reach out. Thank you.